Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, students, and welcome back to Crazy Nurse RN Hub, where learning becomes a tradition. My name is Crystal Merducanes, nurse educator, teaching medical and surgical nursing. As continuation to our topic on gas exchange and respiratory function, we have management of patients with chronic pulmonary disease. Nurses care for patients with chronic pulmonary disease across the spectrum of care, from outpatient and home care to emergency department, critical care, and hospice settings. To care for these patients, nurses not only need to have astute assessment and clinical management skills, but they also need knowledge of how these disorders can affect quality of life. In addition, the nurse's knowledge of palliative and end-of-life care is important for applicable patients. Family and patient education is an important nursing intervention to enhance self-management in patients with any chronic pulmonary disorder. So, as your reference to the respiratory system structures, so I am showing you this image. Now let's proceed to the chronic obstructive pulmonary disease. It is a preventable and treatable slowly progressive respiratory disease of airflow obstruction involving the airways, pulmonary parenchyma, or both. Airflow limitation or obstruction in COPD is not fully reversible. It includes chronic bronchitis and emphysema. Chronic bronchitis. It is a disease of the airways defined as the presence of cough and sputum production for at least 3 months in each of 2 consecutive years. However, for emphysema, it is a pathologic term that describes an abnormal distension of the air spaces beyond the terminal bronchioles and destruction of the walls of the alveoli. Now let's have the risk factors. First is the exposure to tobacco smoke. Also, passive smoking or secondhand smoke. Increased age or old age. Occupational exposure such as your dust and chemicals. Indoor and outdoor pollution. Also, genetic abnormalities can predispose you to have chronic pulmonary disease, such as deficiency of your alpha-1 antitrypsin. It is an enzyme inhibitor that normally counteracts the destruction of lung tissue by certain other enzymes. Now let's proceed to the clinical for the clinical manifestations of your COPD. We have 3 primary symptoms. First, chronic cough. Second, we have your sputum production. And third is dyspnea. For the assessment and diagnostic findings, health history and physical assessment are very important assessment guide for you to diagnose or to know if the patient is experiencing COPD. Also, we have the pulmonary function studies. It is used to help confirm the diagnosis of COPD, determine severity, and monitor disease progression. We also have spirometry. It is used to evaluate airflow obstruction, which is determined by the ratio of FEV1 or forced expiratory volume in 1 second to forced vital capacity or FVC. Now let's proceed to the complications of your COPD. We have respiratory insufficiency and failure. That means your COPD can lead to respiratory failure. Medical management. First is risk reduction. It aims to reduce risk and symptoms. Smoking cessation is the single most cost-effective intervention to reduce the risk of developing COPD and to stop its progression. However, smoking cessation is difficult to achieve and even more difficult to sustain in the long term. Nurses are key in promoting smoking cessation and educating patients about its importance. Patients diagnosed with COPD who continue to smoke must be encouraged and assisted to quit. Factors associated with continued smoking vary among patients and may include the strength of the nicotine addiction, continued exposure to smoking-associated stimuli, such as at work or in social setting, stress, depression, and habit. Also, we have your pharmacologic therapy. We have your bronchodilators and corticosteroids. Bronchodilators relieve bronchospasm by altering smooth muscle tone and reduced airway obstruction by allowing increased oxygen distribution throughout the lungs and improving alveolar ventilation. For your corticosteroids, although inhaled and systemic corticosteroids may improve the symptoms of COPD, they do not slow the decline in lung function. Their effects are less dramatic than in asthma. A short trial course of oral corticosteroids may be prescribed for patients to determine whether pulmonary function improves and symptoms decrease. Long-term treatment with oral corticosteroids is not recommended in COPD and can cause steroid myopathy, leading to muscular weakness, decreased ability to function, and in advanced disease, respiratory failure. We also have the management of exacerbation. An exacerbation of COPD is defined as an event in the natural course of the disease, characterized by acute changes in the patient's respiratory symptoms beyond the normal day-to-day variations. An exacerbation also leads to changes in medication. The primary cause of an acute exacerbation include tracheobronchial infection and air pollution. However, the cause of approximately one-third of severe exacerbation cannot be identified. We also have oxygen therapy. Oxygen therapy can be administered as long-term continuous therapy during exercise or to prevent acute dyspnea during an exacerbation. The goal of supplemental oxygen therapy is to increase the baseline resting partial pressure of arterial oxygen to at least 60 millimeters of mercury at sea level and an arterial oxygen saturation to at least 90%. Lastly, we have the surgical management. We have your bulectomy, lung volume reduction surgery, and lung transplantation. Bulectomy is a surgical option for select patients with bullous emphysema. Bullae are enlarged air spaces that do not contribute to ventilation but occupy space in the thorax. These areas may be surgically excised. Lung volume reduction in surgery this is a treatment options for patients with advanced or end-stage COPD with primary emphysematous component are limited, although lung volume reduction surgery is a palliative surgical option that is approved by Medicare in selected patients. Lung volume reduction surgery involves the removal of a portion of the diseased lung parenchyma. This reduces hyperinflation and allows the functional tissue to expand, resulting in improved elastic recoil of the lung and improved chest wall and diaphragmatic mechanism. This type of surgery does not cure the disease nor improve life expectancy. However, it may decrease dyspnea, improving lung function and exercise tolerance, and improving the patient's overall quality of life. For the lung transplantation, it is a viable option for definitive surgical treatment of end-stage emphysema. It has been shown to improve quality of life and functional capacity in a select group of patients with COPD, limited not only by the shortage of donor organs. It is also a costly procedure with financial implications for months to years because of complications and the need for costly immunosuppressive medication regimens. So this is your bulectomy surgery. It is a surgical procedure performed in order to remove damaged air sacs in the lungs. Pulmonary rehabilitation as one of the medical management. First is we have to educate the patient about the treatment. Also, we have to encourage them to do the breathing exercises, activity pacing, self-care activities, physical conditioning, oxygen therapy, nutritional therapy, and of course, we have to observe and implement coping measures since patients are prone to develop anxiety, depression, and changes in behavior. Now let's proceed to the nursing management. First, we have to assess the patient. Then we have to achieve the airway clearance, okay? That would be our goal as a nurse. We have to achieve a optimum airway clearance, improve breathing pattern of our patient. Also, we have to improve the activity tolerance, monitoring and managing potential complications, and promoting home and community-based care to our patients. Now let's proceed to your bronchiectasis. It is a chronic, irreversible dilation of the bronchi and bronchioles that results from destruction of muscles and elastic connective tissue. For the clinical manifestations, we have chronic cough, production of purulent sputum in copious amount, hemoptysis, clubbing of fingers, repeated episodes of pulmonary infection. For the assessment and diagnostic findings, we have prolonged history of productive cough with sputum consistently negative for tubercle bacilli. Also, we conduct CT scan of the chest. For the medical management, so the goal of treatment here is to promote bronchial drainage to clear excessive secretions from the affected portion of the lungs and to prevent or control infection. So this will be possible by postural drainage, chest physiotherapy, and the administration of your antibiotics. Now let's proceed to the nursing management. So the goal here is focused on alleviating symptoms and helping patients clear pulmonary secretions by way of educating them about their condition and the possible treatment, strategies to conserve energy. So these are the nursing management that we could do for patients who has bronchiectasis. Now let's proceed to asthma. It is a chronic inflammatory disease of the airway that causes airway hyperresponsiveness, mucosal edema, and mucus production. It is a disease with multiple precipitating mechanisms resulting in a common clinical outcome of reversible airflow obstruction. The inflammation ultimately leads to recurrent episodes of asthma symptoms such as cough, chest tightness, wheezing, and dyspnea. Now let's have the complications associated with asthma. First, we have your status asthmaticus, respiratory failure, and pneumonia. And lastly, we have your atelectasis. For the medical management, for the pharmacologic therapy, we have your quick relief medications and long-acting control medications. For the quick relief medications, short-acting beta-2 adrenergic agonists are the medications of choice for relief of acute symptoms and prevention of exercise-induced asthma. They are used to relax the smooth muscles. For the long-acting control medications, corticosteroids are the most potent and effective anti-inflammatory medications currently available. They are broadly effective in alleviating symptoms, improving airway function, and decreasing peak flow variability. We also have the management of exacerbation. Also, we have the peak flow monitoring. Peak flow meters measure the highest airflow during a forced expiration. Daily peak flow monitoring is recommended for patients who meet one or more of the following criteria. First, have moderate or severe persistent asthma. Second, have poor perception of changes in airway or worsening symptoms. And third, have unexplained responses to environmental and occupational exposures. Now let's proceed to the nursing management. First, we have to obtain a history of allergic reactions to medications before administering it. Identifies medications the patient is taking. Third, administer the medication as prescribed and monitors the patient's responses to those medications. These medications may include antibiotic if the patient has an underlying respiratory infection. Also, we have to administer fluid if the patient is dehydrated. Lastly, we have to promote home and community-based care, educating patient about self-care and continuing care. Now let's discuss status asthmaticus. An asthma exacerbation can range from mild to severe with potential respiratory arrest. The term used to describe rapid onset, severe, and persistent asthma that does not respond to conventional therapy. For the clinical management, we have it is seen in severe asthma as well, such as your labored breathing, prolonged exhalation, engorged neck veins, and wheezing. For the assessment and diagnostic findings, first we have the general assessment of the patient, then physical assessment, laboratory evaluation. We also have the pulmonary function test, which is considered as the most accurate in diagnosing status asthmaticus. We also have your ABGs or your arterial blood gases analysis and pulse oximetry. Now let's have the medical management. Close monitoring of the patient and objective re-evaluation for response to the therapy are key. Short-acting beta-2 adrenergic agonists and short-course systemic corticosteroids are given in emergency setting. Now let's have the nursing management for status asthmaticus. The goal here is to actively assess the airway and the patient's response to treatment. So, we have to close monitor the patient for the first 12 to 24 hours. Watch out for dehydration. We also have to assess the hemodynamic of the patient, such as the blood pressure as well as the cardiac rate. Also, we have to ensure that the patient is free from any irritants. And also, we have to review the patient's medication plan from time to time. Now let's proceed to cystic fibrosis. Caused by mutation or dysfunction in the protein cystic fibrosis transmembrane conductance regulator, or the CFTR, which normally transports chloride ions across epithelial cell membranes. And it is characterized by thick viscous secretions in the lungs, pancreas, liver, intestines, and reproductive tract, as well as increased salt content in sweat gland secretions. For the clinical manifestations, we have productive cough, wheezing, hyperinflation of the lung fields on chest X-ray, and pulmonary function tests consistent with obstructive disease of the airway. Now let's have the assessment and diagnostic findings. The key assessment findings are chronic sinopulmonary disease as manifested by chronic cough and sputum production, persistent infection consistent with typical cystic fibrosis pathogens, and X-ray evidence of bronchiectasis and chronic sinusitis, often with nasal polyps. Gastrointestinal tract and nutritional abnormalities in your pancreas insufficiency, meconium ileus, or distal intestinal obstruction syndrome, failure to thrive, or chronic malnutrition. Male urogenital problems as manifested by congenital bilateral absence of the vas deferens and obstructive azoospermia. Now let's have the medical management. First, we have airway clearance. We have to secure the airway. Nebulized medication such as your Dornase alpha pulmozyme. We also have to administer nebulized antibiotics such as your macrolide azithromycin, and anti-inflammatory agents such as your inhaled or oral corticosteroids. This is to decrease the inflammation. For the nursing management, helping patient manage pulmonary symptoms and prevent complications, such as strategies that promote removal of pulmonary secretions, chest physiotherapy, breathing exercises, reduce risk factors associated with respiratory infection, patient education, and adequate fluid and dietary intake. So these are the possible nursing management or strategies that we need to do for patients who have cystic fibrosis condition. I think that would be the end of my discussion on the management of patients with chronic pulmonary disease. I hope you learned something today. Thank you so much. This has been Crazy Nurse RN Hub. Have a good day.